quorum, so I'll bring the meeting to order. Thank you all for coming. The first thing on the docket will be the review of the minutes and acceptance if everyone's capable. We have one correction. We made one typo with a person's name. We just need to change it to their name instead of Maryland. And otherwise, do I have a motion to accept the minutes? And a second.
Got a verbal for me, Dr. O'Shea.
Motion to accept the minutes.
Thank you, Dr. O'Shea.
I went overnight too.
You look pretty good for working overnight. Okay, under old business, we have things that are old from the last meeting. There was a notification of, about BVAC. We had talked about that many times over the phone and over different entities. And there's a few notifications about regional EMS and duplicate notifications coming out. Neither here nor there. It's all kind of in order, but nothing more to announce. It's really all old stuff since the last meeting. Service upgrades, we have none for this time. Evaluation subcommittee report. Yeah, you can talk about it now. Well, basically, what had happened was we had a problem with coverage, with being available, with there being problems inside the organization with diversion, problems with interaction of all, let's say, the staff. I don't know, would that be the best way to put it? Without going into tons of details, but it was related to the Department of Health, who came forward to us, brought us forward all the information, and we met and talked about it and had many phone calls back and forth. But as of that time, BVAC had to reduce its coverage to basic life support and no longer provide advanced life support. And that happened back in April, which was a while ago. So the areas covered by BVAC were taken up, and thanks to other agencies and notably Mobile Life in the area, we've been able to keep coverage going and not have any lack of care for the people in the Beacon area per se. The ALS, they went on to explain why it happened and such, but it was effective April 1st, and they now have a support agreement with Mobile Life to cover wherever they need to do with ALS in that community. Do you want to add anything else? That was the main part of our biggest actions from evaluation committee.
And then one other issue was we did a required review from the fire thing. We provided next Sunday, but we mentioned this because it's unlikely to work with the
Helicopter committee report, David's not here, right? Did they have a meeting? Did anyone meet? I don't know. Okay, we'll put that on hold, just in case. RTAC, Dr. Berkowitz.
Actually, we were both there.
Yeah.
It was basically the protocols, work on the protocols, and pretty hard I'm kind of on my phone a lot of times.
No problem. So basically, I have an announcement under that aspect. The state granted,
Oh, I think the Remac, I was totally out of the wrong number. I apologize.
no, RTAC.
I
The-
see that. I was like, that's my apologize.
It's okay.
Most of the discussion revolved around reviewing the data of transfers, trying to improve the time it takes to get patients competitive care. So we've been doing that at every RTAC. There was a discussion of telemedicine, discussion of the utility of pre-hospital telemedicine, as well as telemedicine from other hospitals. I think that there was some healthy reluctance or concerns about the ability to do telemedicine from a pre-hospital setting. I think greater ease that there is to do it at a referring hospital. And there's been some discussions after the fact with the Remac platform, and I believe they've been talking to Mobile Life as well as Emirates and Westchester counties to talk about to see if they'd be interested in utilizing their platform for pre-hospital telemedicine if they find a way to make it work. So there's probably more to come on that, although I think that a lot of some of the other, like I said, some people had thoughts that it might be hard to do telemedicine from a pre-hospital setting with something that wants to go.
And then there was, you guys were talking about the PEDS disposition issue too, right? Was that this meeting or the meeting
So,
before?
so there was a couple of things that came up on the PED side. One is whether the patients who are at non-pediatric hospitals don't need. There's a discussion about whether they need pediatric care, and this is something that I think that we need to work on to support us. The goal should be to prevent unavoidable transfers. And I think that in general, I would say any community hospital that wants to transfer a potential pediatric trauma, I think that's reasonable. But I think that we need to find a way. What's the approach that a level 2 or non-pediatric center? What should they be transferring every child as well? Or this is something that's an issue that's coming up that I think that we haven't really resolved yet. And I think that we do think that there's a risk for some unnecessary transfers, which is obviously a drain on the system.
And also, the parents get pretty upset too. I mean, that's the other thing from a logistical point of view. I find that the families, if they go down and they get discharged, which is, fine, they get evaluated, they're at a trauma center, it's a level 1 trauma center, get discharged, they kind of have an issue about it, and yet, I guess they don't see the big picture. When the kid falls into the field triage criteria for true trauma, what do you do? So I think we have to work out a solution there, and I agree with you. I don't think there is one answer. It's going to have to be something we look at, but, the falls, especially, things like that are really a kid that's, still looks pretty good, and yet traumatically had a kinematic injury that falls under that criteria to be seen at a level 1 trauma center. It's difficult. And I think it's difficult for the providers too, because they're kind of caught in the middle. But I think most of us will agree a really traumatized child belongs at a level 1 center and a pediatric center, and that's kind of a no-brainer. It's these ones that are minor but the
Criteria.
Yeah.
I think that the PCON guidelines are really good, and
Yeah.
I think that if all the docs are following those, I think that would probably save us a lot of those questions, of what to do. Certainly, and if you fall into the group of observation versus CAT scan on those guidelines, then that's a discussion to have with the family. With the understanding being that if they get transferred, they might get a CAT scan.
telemedicine portion.
Yeah, on the field,
Yeah, well, we've spoken about it somewhat. We started some of the conversations since the last RPAC meeting, and we talked about getting our protocol committee together and expanding it slightly to include some other additional folks. One of those is Dr. Daly has agreed from the staff to be on a phone conversation to start addressing some of these needs and then hopefully take it statewide, because there is lots of confusion for the pre-hospital providers. And then, certainly, there were some valid questions that have been asked, and we just want to make sure that we get those all addressed. And so Dr. Stubno has agreed to be on that conference call as well. So Bill and I are going to work on, over the next couple of weeks, getting that conference call scheduled so we can try to just get a tag going to discuss this and see if we can move any place.
Yeah, I think that the pediatric question is very difficult because it's not always cut and dry, but I think the worst case scenario for people for now is they go to the institution they feel is the correct location, and if there's any question, they go to the closest trauma center and let them, evaluate the child and decide and move from there. I think that there is going to be many questions that come up, many issues that change it one way or the other. I know the EMTALA thing with the helicopter is really not an issue as long as you have it all set up and the agreement's there. So I think it's more a decision-making process of where's the best destination for this child. And sometimes like we talked about before with other cases, going to Westchester if need be, we can see them and launch them, and that's the thing of a discussion of with the trauma center, I have this kid, I think this kid's, got multi-trauma and needs to be there, and you'll launch him and get him there sooner rather than later, and don't waste a lot of time on imaging and everything.
So I know that the AMS will launch the helicopter if you call and say, hey, I need a helicopter. They're not going to wait for acceptance or anything else like that. They'll get things going. And the same thing is true for when they're down and you want our critical care ambulance to really launch. In fact, they're self-launching themselves now in a way, because they have more access to transfer calls, so they can kind of see what's going on, and then they see, hey, there's a sick kid somewhere. They show up.
contact hours. Did I hear that correctly?
Yeah, it sounded.
Yeah, okay. Go ahead, John.
I can give you the data. I mean, that I can get you. We have a pretty robust data, so we can work on that. I want to just disambiguate something because I think that we're talking about two things at the same time. One thing we're talking about the really sick kids, which I think is we know what we want to do. We just have to find a way to get there. And the other thing we're talking about is the not so sick kids, who now you have the CDC guidelines saying suggesting that they show up at a pediatric trauma center, who show up in a non-pediatric trauma center, and it's a question of what to do. And I think that once you
Marcus just said, you know, every level 2 trauma center should be able to take the majority of such, except for the ones we see are just so catastrophic and require a higher level. And, you know, that's, I don't think, a question. But when you're going in, is that a nurse saying that to you, or that's the ED doc saying that to you? Why'd you bring the patient here?
I second that.
Change the name to techniques.
So, I mean, then it has to be looked at as, why is that institution a level 2 trauma center then? You know, because I think you're talking about level 2, so I'm reading your mind.
I don't think that staff
Well, remember what happened when we got rid of backboards? So I think there's always issues, I know, but I think that, and we probably could clarify it a little bit better. The problem is, it changes so much, you know, like I'm gonna announce, and I started to before, that Orange Regional now is a level 2 trauma center provisional. They have a year to get an ACS, visit, audit, and, you know, then go from there. And like you said, the changes occur, but I think that we have to, you know, I don't know if there's a, like in before there was so few trauma centers that it was easy for us to make that flow diagram, to be honest with you. Right now, with it being a dynamic kind of process, I don't know if we could do that, but I think the best thing that a pre-hospital person has is pick up the phone and talk to medical control, and you can ask the question.
So,
Mike.
I mean, first of all, I applaud the group for having this discussion, especially with pediatric trauma, because certainly the state data, you know, is pretty clear that all of our patients are not getting where they need to go. And there is a huge educational component that's going to need to go along with this. But I think it's important that we, you know, continue to move a tag forward, to look at, see if we can develop criteria, see if we can just all feel comfortable with this EMTALA thing. I know that most of us feel that we're okay there, but we need to just satisfy that. And let's bring the state trauma group into this, and we can just continue to move this forward. I think we can report back, you know, as we go on. But there's some huge educational components, because a lot of EMS providers want to pick that patient up and get them to their local hospital, regardless of the capabilities. And I don't know that that's the appropriate decision in all of these cases.
Just my understanding, is that, you know, why do you bring the patient here? Is that happening only with pediatrics, or is that happening with adults as well?
Outside looking in, I thought maybe something was correct. State or health services, you know, but then it seems to be paranoid that some of the staff will be reducing almost a reaction rate. Maybe people just put it up defensively. Again, bring this patient.
Well, I think the safest thing is,
In a relatively short time, we got that response.
the safest thing though is if you know, you decide and you bring the patient to an institution, you have an ED doc there, then that's it. They go, they evaluate the patient, and they decide the best thing. We can't, you know, for right now, that's the way we should do it, and that we make sure that, you know, there's no big decision making in the field. If they can't decide, then they bring the patient to the, you know, trauma center right next to them, or the closest one they can get to. We can't have them sitting in the field wondering and watching and, you know, feeling like, am I gonna make the wrong decision? That there is no wrong decision. They make a decision, they do it, and we go from there. And we're gonna be able to find and fine tune maybe a process here, but we have to still continue on, because we're, you know, a day-to-day basis doing this stuff. Mike?
Well, ultimately, too, you know, who do you even call? So, you know, if you're out in the field today with a pediatric patient, first of all, whose pediatric definition are we going to use? What age are we going to, you know, we're talking about signs of puberty. I think that's something that needs to get cleared up as well, because there are several, I think 3 different standards for pediatrics. But additionally, do you call your local hospital or your local level 2, or should we be calling our pediatric level 1 and saying, should the patient be coming here? So that's a question. As a provider in the Hudson Valley, can I call Westchester
bombarding these guys with calls at the medical center. Can you imagine them leaving their patients every time to come to the radio for that volume? Maybe it's not a lot, but still, I think you need to, ask your local medical control.
Everyone will know, but I mean, I think that, the RTAC says that, when we do the ACX definition, the active, 14 and above is adult. We should all be using that.
Yeah.
But see, the regional protocol or the collaboratives don't use that. So that creates a challenge for us in the field because our pediatric definition is different than the ACS's.
They use puberty.
And that's, and obviously that's where Dr. Daly getting in on this conference call would be helpful as well. He'd agree to do that. Because that's a challenge.
Seems like when we went to specialties for stroke centers and STEM centers, with adult patients, it was a no-brainer
bound again, because it's just like, say, you're driving from Sullivan to New York City, you're transporting a patient, and the patient goes bad, and you call medical control at St. Luke's or at Orange Regional, you're getting information from them. They're not bound by EMTALA because you're driving by and asking for medical control. That's under a, regional setup for our protocols, for our medical control, both online and offline, to assist you guys.
Really, at the end of the day, we should just be concentrating on what the right thing is and not really the legalities of it. Because what is EMTALA? Ultimately, it's the hospital a $50,000 fine, and where the court, whether it goes to federal court or a regular court, there's a malpractice trial. Other than that, I mean, it doesn't really affect us, and we should probably just worry about best medical care. Because if we're working on doing the best medical care, then the EMTALA issues aside, as to where the venue is can be settled later if something bad happens, but we're doing the right thing. And that should be our focus.
Okay, healthy discussion. Good job, Dr. Berkowitz. I'm gonna.
Especially that we talk about the
Yeah, I know. Will somebody hit him and wake him up? No. Dr. Stu Miller, I'm gonna back up for a second. Did you want anything under helicopter report? I skipped over to go to.
Thank you.
It's fine.
The only request for helicopter is that the collaborative protocols are shared, and we also share the helicopter operations guidelines. As it used to be, I know that the protocol, the collaborative protocol, was the volunteer one. And so we've done a lot of work with years to provide
Okay, thank you. Next, quality improvement, Jeff.
Just about finished with this year's study for cardiac arrest, so we'll be looking for a new project for next year.
Maybe we have to do trauma.
Actually, I'd like to say that I think that we should be looking at appropriate destinations regardless of the specialty type. We're getting more into specialty type of transport, and I think that that's something that we absolutely need to look at. We need to raise the awareness of it and see if we can improve the system. Because there are patients of all types, stroke, different varying levels of stroke, STEMI, and trauma, but I think we need to improve that.
Okay, nice segue. Protocol committee, Mr. Benamati.
Thank you. So, an update went out with regards to the credentialing examination. Over the last several months, we've been changing that process.
With regard to the credentialing,
Credentialing examination. Over the last few months, several months, we have changed the process. It now requires for pre-hospital providers that they take an open book exam at their regional office.
kind of segues into both our new business and CMAC, because we had to pass this at CMAC. And the point there was, if a agency, a BLS agency, wants to acquire the technology and the equipment, we're not going to make anybody do it because it's an expense, then why not have more information? And so that was what it was. It's acquisition of the ECG. It's not interpreting, it's not doing anything else with it. However, if we identified and saw people, and an elderly woman who's nauseous and diaphoretic, they acquire an ECG and she's having an acute MI, they're going to go to the STEMI center versus just going to the hospital right next door to them. So the acquisition is what we're looking at, is could it get us closer and quicker to acute MI patients and help. So that was the point behind it. Not so much that we want, make it mandatory. We would not. All these things start with a certain process. Now, to be able to do it, the BLS agency, just like if they're doing albuterol, just like if they're doing EpiPen, has to apply, has to have a medical director on board, and has to have somebody sign off on it. So there is a process. They have to be more of an established, organized BLS agency than anyone else. They have to have that process already in place. So to me, I wouldn't want to hold up having another venue, another avenue to have more information delivered, especially in some of our remote areas where, we rely on these people to, take care of the patients and be the first on scene. So that was the point behind it. CMAC had passed it. It comes down to our Remac for us to vote on it, and we have to vote on it today. Do you want to pass it around? That's the official Department of Health BLS acquisition of 12 DKG protocol. And people can look at it because we have it on the business today to vote on. But that was the point behind it, I think. Not so much that, it's a thing that we have to be worried about per se, but it's a process. Just like we advance their care in other avenues. When I first started, they didn't do, glucometry even. Andy.
Put that in perspective, where does work central seems that seems fine. Here,
because of finances, and we didn't want to say that, you know, these volunteer agencies who don't have a budget has to go out and buy, you know, X number of glucometers or has to go out and do X number of things. However, and they need to have some, well, they need to be married to a medical director and work with a medical director. And I think that's where probably most of the problem comes from with the BLS agencies. Never really had that. They had somebody that sometimes was a medical director and most of the time not. And they just did their volunteer agency stuff. But I think Dr. Papish is bringing up a good point. We have to continue to move forward, I think. I think we always have to continue to strive to increase care, increase the level of care. And even if they have a problem transmitting it, they're still walking in the door with a 12 lead. So you haven't gotten the patient.
They can't even print it, can't even print it. It's a completely, it's a blind device. So only the receiving, so the person, the agency that does this first will need to buy their equipment, and they need to buy the equipment for the hospital as well.
Well, not if they're hooked into the same, because most of us use a certain type of.
No, it's a different system. They won't be able to, they can't go into the Zoll system, and they can't go into the Physio system. It's a separate device that they need to purchase that doesn't even give them a screen in the field.
Just from my perspective, just one thing, so we receive those all in Physio, and just being able to, I mean, I don't know, you know, we use the different hospital I'm sitting at, we try very hard to make sure that we get all the transmissions, but just getting two different feeds is a nightmare. I mean, a third feed that is not compliant with each other, they don't want to play, no one wants to play, you talk to Physio, you talk to Zone, whatever, it's like, no, it's their fault, whatever, but we have a better system, why can't they just send to us, passport, whatever it is. So I mean, that's a real operational barrier, especially now that we're a city, like a dedicated city center, that we still every few months have something that happens where we stop getting transmissions somehow, and it's monitor set up, or it's the computer set up, or you know, whatever it is, figure it out. I can only see another layer of complexity. It is going to be, it'll be challenging. I'm sure that if, on the other hand, I do know of an agency in our region that's very pro this, and it's because they have testing patients who they you know, that get transferred to BLS, and they can't, you know, they don't know, and they feel bad when they find it out. And I feel for them. I think that in a limited way, there are probably a few agencies where this would be very useful for, but from the hospital perspective, it's going to be challenging.
Who makes this?
Zoll and Physio aren't done.
Yeah, I think the one that Dr. Daly had at the meeting, I think actually it's an internet-based, cellular to internet, and the initial doctor that interprets it, I think, was in Israel, who then phones the hospital and then faxes the transmission over as well.
Never had that before.
But it goes to Israel
And
for,
hey, the doctor reads it, you know?
except from Friday night to Saturday.
Goes to India.
Yes, in the back.
It really is all true.
So, I'm Jim Hutchison from Sheriff Hospital, and we have genetically adopted BLS. We asked them to send questions to us with Android. From Sheriff Hospital, 50% of our managers who are participating in this program. And we are regularly sending
Is there a rule that says it has to be blind? I mean,
The
could they-
protocol is there.
they're-
Can you
they're not
pass it along?
interpreting it themselves. Is there any reason they couldn't?
Well, the only reason that has to
Rosie, did you read it?
Just transmit on a phone.
Operationalizing this, the policy says on a receiving hospital. I'm certain that's purposely made. What is the intent? That it goes to the hospital where your medical director
Raise your
works?
voice, Dr.
Sure. Do you go to the hospital where your medical director works, because your medical director works at a hospital? Does it go to your local hospital in your community? Does it go to a STEMI center that you might be transporting a patient to if there's a STEMI? What is, what would be the receiving hospital if we were to approve this?
Well, what it's set up to be is who you're going to talk to and who you're going to direct it towards. The equipment that Dr. Daly had brought to the meeting was that you hook it up with a specific institution. And so you work with that institution just like they're talking about in Connecticut. And you would be transmitting it to them.
What's the intent? Which institution? Is it go to the STEMI center so they
Yeah,
can
you-
call on control?
Yeah, it's the one.
Online medical.
Yeah, it's the one you designate and have the receiving center you generally go to. So, Goshen would be, Orange Regional. Goshen Volunteer Ambulance Corps as just an example would be Orange Regional because that's where they bring the majority of their patients. And so they would set up a system to be able to transmit these EKGs. Now, there's many issues, I think, I don't think it's foolproof. However, I just find that I think if we can move people along, have people do things that'll help us. I know there's issues of people not doing glucometry and not doing albuterol and such, but we can't force BLS agencies to do certain things, but we could give them the auspices and the ability to upgrade their care, to give another higher level of care and another bit of information that helps the doc and the ED, and that was the premise behind the New York State Department of Health.
So I agree that it is important to have everyone practice at the top of their license or certification. This would be a wonderful step toward that for BLS providers. I feel for your sentiment that BLS providers don't want to be practicing at the highest level. You're doing all of the things medically available to them to help our patients. I don't know if I would hold off on this in the hopes that they would do albuterol and mix them up with glucometry. But I would question, should we recommend that these go to the STEMI centers? So the STEMI centers can say to the BLS agencies, yeah, that's a STEMI, bring them here, please. Or, no, you can go locally, much like you were just sort of alluding to with trauma. You can tell the trauma center to say, is this a trauma patient you want? Should we have these go to the STEMI centers? Then there would be fewer hospitals that have to purchase receiving centers. Those hospitals more likely are already used to getting more phone calls, and the physicians would be more willing to take those phone calls and spend the time to look at this transmitted EKG rather than relying on nearly every hospital in the Hudson Valley to buy something and have all of those physicians willing to be available to read an EKG in a local center.
Yeah, I think part of this whole issue that we look at this from the state and adopt it if we want, we make it the way we want because we're the officials in this area. The Hudson Valley, we know the Hudson Valley. We know what their capabilities are. We know what we have. So we can designate it as the receiving institution is a STEMI center. John?
Do you have an idea of what people's interests are regionally? How many agencies?
We're talking about probably 2 agencies.
I was gonna say, I think
out
we've
of
heard two so
40,
far.
so-
Jeff, I think this got the two.
Yeah, it's not a voluminous amount.
So this might be actually essentially a very specialized limited program that is to deal with gaps that have been identified in certain regions, which in that sense it's great. But if every BLS agency is like, I'm doing this, and I can see how that would be an issue where if it's just a couple of agencies saying, I want to do this, they're gonna find a way to make it work with a hospital.
And I think the BLS agencies that become more involved and that take their care to another level and do these other things have an involved medical director. And I think that's been our problem, Andy, with the history is that we've not always had that communication between BLS and ALS and to this body itself. And so I think, sometimes we can have a process where you have a more involved medical director with a BLS agency, so. Correct, I agree with you. You know we've had this discussion before, I mean,
And that's the problem in Ulster County. I've got a couple of clients that want to go to BLS and Narcan, Commentary and Narcan, and their medical directors are going, they can sign off on it. What I think we need to do is, I recommend, we put together a quick fix the end.
yeah, you get a new medical director. All of us said the same thing and went,
It's not that easy to get them. Yeah. I wind up getting one of my ER physicians to sign off every day. I think, find somebody.
Well, that's the best person for it to be anyways, right? I mean, we have had, in the past, would talk about an agency, and I'm like, who's the medical director? I've never even heard of the person. So it's much better for it to be an affiliated ED doc or somebody in what we're doing, in the gist of it, that's staying up to snuff with what we're doing.
Can we develop a list of who all the medical directors are and send something to them and say, hey, this is the level of care that we've gone to, and we strongly recommend that you work with your agency to get to this level.
Absolutely. I think you have a few directors in your area right here that can address that issue. I think there's no question it'd be helpful to have more involvement, it'd be helpful to have more communication, just like when we did the educational rollout before. I mean, I think people were receptive to new information and that we're even out there wanting to get them involved, wanting them to come to a higher level, wanting them to, bring it up a notch. So, I mean, the more we can do, the better off we are. Volunteerism is a dying breed. There's no question. But I don't think that means we stop what we're doing. I don't think that means that we put a ceiling on what people can do. I think we have to allow people to do and to move forward. And that was my point behind. It's just acquisition. And if they can do it, and if they have a system set up, and they have somebody to do it with them, and a medical director, then I wouldn't hold them back.
And I think the way the protocol is written is particular policy is written. The EMS agency, in coordination with the hospital, can elect to this volunteerism. So it's not forcing anybody, it's not pressuring anybody. If you have a system and you feel in combination with your receiving medical center that your patient population will benefit, then you can pursue
Yeah, and it was not to make it a monetary.
a mandate.
Yeah, that's why it's not mandated. Yeah,
Then we vote?
yeah. So you want to make the motion?
Yeah, for the motion that we begin permitting 12-week acquisition programs amongst BLS regional,
Amongst the BLS.
BLS providers.
In the future.
We'll have to get a second.
Okay, I'll second that motion. All those in favor? Unanimous. Thank you. What were you going to say?
Just for technicality, the state does talk about BLS and advanced emergency medical technician levels. Certainly that's another big topic.
Yeah.
At the state level.
Yeah.
So maybe for the motion, you should revise it to be consistent with the state protocol. But that's you.
Yeah, I mean, I think we have to,
It has to be consistent.
yeah, it has to be consistent with,
So then it would be basic life support and advanced emergency medical technician level.
okay,
Talking
we,
about the 2s and 3s, I mean, that don't really,
Yeah.
yeah,
And again, the state right now is re-examining
yeah,
that whole issue.
that was a huge topic at
That was a huge topic last
CMAC also. Okay, so we'll advise the verbiage of the motion and just add it for basic life support and advanced EMT providers.
And then the other question is, should this then go to the protocol committee or another group to develop a process? Because obviously there's a process that's going to need to be developed at a regional level before the approval is made. Right or not? Do you need a process?
It shouldn't really be any different than any of the other adjuncts that are out there.
Yeah, because we don't oversee the glucometry and the albuterol, but they have to
Well,
have,
this one does require an approval letter. So
Right, well, all of them do actually too, because they come through the office
Okay.
and we kind of rubber stamp it. So I see every single one that comes through, but they have to have the appropriate paperwork filled out. They have to have the protocol, they have to have the medical director, they have to have, you know,
As long as Jeff's good with that, that's all that
okay. Okay, thank you.
matters. I'm on board with that.
The last thing under the new business is the collaborative protocols that Mike had brought up. Remo presented their protocols to CMAC and had them approved. It was the same protocols I gave you at the March meeting. However, what they were had some changes in verbiage, changes in some semantics and things. We saw some literacy and kind of technical issues the way we had written some things. So we've adjusted some of those issues and corrected the typographical errors and made it into the same format. Like Mike had said before, we moved out a lot of policies that belong under each Remac and just kept it as a medical collaborative protocol. It did pass the, remember I told you about the patellar dislocation? That did pass. I couldn't believe CMAC allowed it, but they did. So that protocol's in there. And the version you all saw was basically the version that went through. So we put it out for a commentary. Most of the material came back. We forwarded on to the collaborative committee. Hudson Valley had quite a few comments, and most of it was pretty straightforward. I didn't think anything was unusual. However, there was one part, Mike, do you want to bring up the part about this disclaimer?
How about at the next meeting?
Okay.
How about, so we can adequately prepare to have the discussion, just, and maybe we'll learn a little bit more about the protocol by then.
Okay.
The discussion is going to evolve around, the use of judgment by field providers more than written protocols that we've had. So provided the paramedic has the skill, provided that the medication is Avox, and they contact medical control, the provider medical control have additional flexibility. But that's going to be a huge educational component when we roll the protocol out, because paramedics traditionally have been, if it's written, I can do it. If it's not written, I can't. So it's a change in the philosophy that we're going to have to really look at in greater depth as we move forward.
Well, I think
It's good for the
Great
higher
paramedic.
trained paramedic. For the lower trained, it raises some concerns.
well, that paragraph you pulled out, though, is really a typical legal paragraph that everybody uses whenever they write guidelines, that this does not supersede good clinical judgment in medical care. I mean, that's what everybody puts in every single, if you look at every protocol and thing that's there. So that's why that paragraph is
So we
there.
can talk more about it next time, just because we're going to need the physicians to have a little bit more latitude when it comes time to doing something, because there's not going to necessarily be a written protocol for it any longer, but a general accepted practice and guideline.
So, if I may piggyback on that, again, the nuance is in the clinical decision making, and it boils down to education. So, combined with the rollout of the collaborative protocol, there's going to be a robust training program with video and streaming. So, tentative dates for that are July 11th and 12th, Monday and Tuesday, multiple sites. So, educators from all over the state will come down, and we'll have scenario designs to sort of bring the collaborative protocol to life, and we would love for everyone to participate. Certainly, this is not limited to physicians, but educators from all types of varieties. July 11th and 12th are the tentative dates that we're inviting.
And I think what the process there is what we're talking about is standardization of how we roll these out, how we educate people, how we bring everybody up to snuff, region-wide, and just that we make sure when we roll it out upstate, when we roll it out, in Remo area, when we roll it out here, when we roll it out in Westchester, that we're all going to be given the same information and people can utilize these video projects and use them as the teaching tool so that we are all there. Now, it's good that, you know, as many people show up for this educational process as they can, because this way we'll all be on the same page. However, just like when you know, project from Cushman and, you know, the backboard, that was a great tool that we could all use. So this is the process behind it. And again, you know, just to keep going on with providing the education in a standardized format.
So, and we really need, you know, Dr. Ashad is doing a lot of this. We work with Dr. Fugular out of Syracuse as well. And they're trying to develop a real progressive training program which will take a lot of pressure off of the individual agencies, because you will simply participate in this program. And I believe that that's what you're going to be then organizing on the 11th and 12th?
Yeah.
Okay.
We're recording the training scenario simulations cases, we'll produce them, and then load them onto a learning management system that should be accessible by any hospital provider in the state, and then we'll track them. So that's a great effort.
Yeah, I mean, it just, because we saw the last time that it was too many open holes, so this way it's gonna standardize it all. Now, I have on the agenda to vote on the new protocols. Does everyone feel comfortable in the room that they've been able to review the protocols in a fashion that they're capable of voting on here, or do you need me to table it to the next meeting, which is September 12th, so you have a little bit additional time to review, because it's not going to cut into our,
Is there a document, could there be a document somewhere which
yes. Yes, I can get that to you. What I sent to everybody was just the full gamut of the protocols, but I can absolutely take out of it the big things, because I keep notes on every single time we meet and what some of the stuff, the discussions and things are, so I can get that to you, absolutely. It's really not much change from what you have from the last meeting, really just more typographical and the way we set it up, but I'll send it out. Yeah. So why don't we do this? Why don't we table the vote till September, and that way everybody can have a chance to look at it, and we'll go from there, because it's not going to change. Like Michael was saying, we're not going to be able to roll it out till probably the first of the year anyways. By the time we get the education and everything done, we will present it. CMAC is September 24th, 25th? I can't remember the next one. I think it's at the end of the month, so we should be okay with that. I'll just check that time frame, and we'll go from there. So, oh yeah, so it's right after us, so we can. So I will say 13th to 14th. I thought 24th, 25th. I will. So we'll table the vote till next time, so everybody has a chance to look at it, the final version. And I'll get it out to you, and I'll put a little bullet point issue so you know exactly what the changes were from the last time. Mainly it was really formatting, additions, and actually removal of things. So that brings me to the CMAC report. We talked about most of it. The other thing from the Department of Health, what we did was, under our EMS, the Bureau, we voted on removing some policies and advisory. They were actually advisories, sorry. We rescinded 2 advisories that were out there, biphasic automated external defibrillation and emergency care of patients with hemophilia. We rescinded those policies. They were from 2002 and 1997, and we rescinded those as of the last meeting. Also, mask trousers, and hyperventilation in severe traumatic brain injuries. These were all advisories that were sent out over the years, 2004, 2003, 2002, that we rescinded. I can send the list around, but just to announce they're out of the Department of Health at this point. Yes?
With the removal of the mask that had
Yes. And there was one other thing, the pelvic binder, we changed the verbiage on, and, there was one other thing I'm forgetting now.
they added the pellet.
Yeah. I have a couple of announcements from the state regarding that. The Board of Fire Commissioners has removed Woodburn Fire Department authority to operate a New York State certified EMS agency as of February of this year. Until that time, the department has to receive a full completed application before they take them off suspension. So this is a notification from the state regarding Woodburn since it's in our area. I mentioned that New York, the Department of Health also gave provisional level 2 designation to Orange Regional Medical Center as a level 2 trauma center. There's also a great deal of information come out from the state regarding, medical drug shortages. It's this never-ending, constant list. And one of the things the Bureau brought out was a notification that more medical will no longer supply controlled substances for their customers. So that was a change and a transition people have to work with and to move to other organizations and companies to help them out. We talked about BVAC. Rockland Community College has come out with a statement through a thorough investigation into the EMS program offered at the college. After review of the past 5 years, the college administration has determined that continued low enrollment and rising costs prohibit the continuation of the program. So as of August 31st of this year, Rockland Community College will no longer offer courses in emergency medical services, paramedic, and EMT training. There was some information that came out regarding, the new laced heroin. I think this, we circulated this all around with pretty much emails, and people had noticed it. And it was a letter from to get out to all the Remacs, but we sent that out electronically at the time. This was back in March. The Department of Health has also sent out, Daniel Clayton sent out a notification for forms that you can see on the regional website, mainly looking at and directing towards the blood transfusion program. Those forms are on the website and available. As of this date, we have one of the only agencies doing the blood transfusion, and kudos to them for following through on that process, because it's been an arduous task, I know. That was it on my new stuff. I have to read some Department of Health citations, and then we can go into open forum. So from the Department of Health, Michael Hilbron-Rada out of East Elmhurst has received a citation, suspended for 1 year as of March, and assessed a civil penalty of $2,000. The suspension is for the individual certificate, and the enforcement is a matter of public record. In addition, Raul Steed out of New York, for a violation of Part 800, has suspended for 1 year and assessed a civil penalty of $2,000. Also for a violation of Part 800, Joseph Sumeski out of Oswego, New York, is suspended for 1 year. The suspension was effective March 14th and assessed a civil penalty of $2,000. Jared Wells out of Ogdenburg, New York, was given a citation for violations of Part 800, and it was effective March 14th, 2016. And lastly, Christopher Jenkins out of Hammondsport, New York, for also a violation of Part 800, assessed a suspension for 3 months, effective in March, and placed on probation for 3 years and a civil penalty of $2,000. I have to read all those into the minutes. Open forum. Anything anybody wants to bring up? the RMAs, they're supposed to be contacting medical control, that's not a question. So that has to be dealt with right at the level of the agency, because they're supposed to be contacting, there's no question about it. That discussion you can have with the medical control physician. I think that, once the person comes in, 90% of them, in my experience, are always so pissed off, they want to get out of there anyways. But I make sure that they're capable, they're understanding, they know what they're doing. I can't force them to do anything. I can't force them to have any care, but I'm going to make sure I'm comfortable with it and that they're awake and they're, don't need to stay. If somebody is like kind of doffing off again, I don't let them go home. I don't let them sign. They're not capable of signing AMA.
Is there any way we can start tracking the RMAs of, I guess, first responder, then EMS providers coming in, RMA, to make sure medical control is being contacted? My concern is we have people showing up at one of the meetings, oh yeah, they just come in RMA, they signature and leave. So I know it's been happening that medical control has not been contacted on a regular basis, that they have not been contacted on all uses of nasal narcan by first responders within this agency.
So where would the reference be? So just this, if this scenario plays out, it could be, police department arrives, gives the Narcan, and a BLS agency arrives 20 minutes later, takes potential alert, and oriented and signs off. I don't know where there is a policy.
BLS, we're not going to, only ALS.
That's what I'm saying. I
Yeah.
don't know where BLS.
There isn't, not that I
is
know of.
going to have to do that.
Yeah, there's not anything from the BLS perspective.
John's asking, I think, for a more affirmative, anytime Narcan is given pre-hospitally prior to their arrival, it's gonna require medical control. I mean, I think, right, is that what you're saying?
The New York State BLS protocol is now stated, even if the patient is conscious, alert, oriented, you suspect either alcohol or drugs on board, there is supposed to contact medical control and a police agency as part of the BLS protocol within that March. And I'm not sure if the BLS agencies will get there before ALS, and if it's conscious or oriented patient is going to RMA, I'm canceling ALS, or if we have ALS providers that are walking into a patient that is conscious or oriented, yeah, I don't want to go to the hospital, I'll pay your sign here and have to go pick up. And medical control not necessarily being contacted. I wonder if there's a way we can say with all the agencies in the region that Narcan use by a first responder, and then the EMS agency comes in to make sure that medical control is being contacted. These people do realize that, 30 to 80 more minutes is actually looking at halfway through. Once that wears off, if they've sat there going back to inject themselves again and they're high back, it takes us 60 or 70 minutes for this person to finally say they're going to already have one. When we start talking, then we said, I prefer them not to increase my business, try to prevent that from happening again. Any providers will be able to take you, just, I'm not going to go, we just sign them off. Anybody got the outcome that could happen again. And the only purpose of giving Narcan is to try to give these people one more chance to go and have to get themselves fixed. But leaving them in the house, what they are capable of doing is setting themselves up as they were when they were
I think that we could make a definite, strong recommendation that they follow the BLS protocol, because that's the way the state put it out, and if they're going to have that capability of Narcan on, to their disposal, they have to follow the protocol. I don't know if that has to go out as a advisory or a reminder. I can research that a little bit, the politically correct way to do it, but absolutely from this body, we can put out a letter to them. It still comes under their person who signed off on their Narcan. That's the person who's really responsible there. So it's that it goes back to the medical director again. And we can put that so that people understand what it is. But it sounds like it would be better, and that's okay to do, but it sounds like it would be best to look at, is this a specific agency, or is it a global county area, or is it one little hamlet? So that if we could look at it, we could identify who the medical director is, go right to the source and say, listen, do you know this is what's going on? Also, that's another way to identify it, but you and I can talk about that. All right? Because it's very important and it shouldn't be happening.
I wanted to emphasize, yeah, I think we all agree, the high-tech are a big, all the time, I've taken several of these calls.
Yeah, me too.
Delivering and all that.
Yeah.
And it was just funny, over at Arlington, that Arlington Air Group, kind of Christie Police Department, but does give take an arc. Their policy, they give an arc and a next one, they come, that meeting, transport. Now, if they show up after Arlington shows up, Arlington is the one they help on Arlington on that. So we're walking and we have the police department that's gonna straddle the line, going, yeah, we're gonna enforce the scenario A, but not scenario B. It's open it up over the police department and
And that's the town, that's the town. It's interesting when you talk about these concepts from a data perspective. So, Dr. Fred Manifold, EMS medical director at San Antonio, Texas, did a death registry study of patients who received intranasal Narcan revival, how many ended up in the morgue in 72 hours. And we would all guess that there's some number, right? Not saying that it's not possible, it just usually does not happen. And I think the criticality of decision making is to make sure that they can have this capacity. And the safest way to do that is, get a full assessment of vital signs because they would not want to
Yeah, and that's not a problem. But Arlington's not going to be providing services anymore, right?
it's still doing
Okay. I thought that was changing. I misunderstood. Okay.
They'll be doing transports.
Okay. Interesting. Okay. So they're gonna throw them up onto the ladder when they're ready to go. Yeah. Okay, open forum, any other issues? Anything anybody wants to bring up? Can I have a motion to adjourn? And a second. Thank you. Thank you, everybody, for coming. Thanks, Dennis.